Hi everyone, and welcome to today's webinar, Reducing Infection Rates Through Optimal Healthcare Design, How You Can Change Your Environment to Positively Impact Patient Safety Outcomes. My name is Jason Thompson. I'm a Communications Officer with the Canadian Patient Safety Institute, and thanks to everyone for joining us today. This is the fifth in our Human Factors Call series, and if you've missed any of the previous webinars on human factors and are interested in checking them out, recordings are all available on our website. This one as well will be recorded and posted within the week, so if you want to go back or send this over to a colleague who you think might be interested, you'll be able to do that and they'll be able to take part as well. To stay on top of any future webinars in this series or anything else that the Canadian Patient Safety Institute has going on, I encourage you to visit patientsafetyinstitute.ca. If you haven't already, and sign up for our newsletter. You can also follow us on Twitter at patient_safety. And you'll find out about all of our latest offerings there as well. Before we get going, I'll introduce the CPSI staff who've worked to put this call together for you. Tricia Swartz is our Patient Safety Improvement Lead, and Gina Peck, Project Coordinator, is our technical host to this call. So thank you to both Tricia and Gina for their work on this. Next, I'll introduce our speakers. First up is Dr. Tracy Hurley. Tracy is a national investigator with the Healthcare Safety Investigation Branch in the UK. Previously, Dr. Hurley worked as a human factors specialist at Healthcare Human Factors, a partner of the University Health Network in Toronto. It was there that Dr. Hurley conducted studies on the use, design, and environmental context of personal protective equipment. Our second speaker is Professor Chantal Trudel. She is a faculty member at Carleton University's School of Industrial Design, Faculty of Engineering and Design. Professor Trudel is an ergonomist, human factors specialist, and industrial designer with professional experience in healthcare planning and design. Last but not least, we have Janet Brintnell. She is a clinical nurse manager at the Ottawa Hospital Neonatal Intensive Care Unit. She's a registered nurse with extensive clinical experience in the neonatal population, and she has been a clinical manager for both the NICU and the Special Care Nursery for 17 years. She also holds a master's degree in health administration. Throughout the course of the call, if you have any questions or comments for any of our speakers, we encourage you to enter them into the chat box. Once the three speakers have concluded their presentations, we'll have time towards the end of the call for a brief Q&A. So send in any questions as you think of them, and we'll be sure to get them queued up for the end of the call. With that, I'll turn things over to Dr. Hurley to take us away. Thank you.
Great, thank you very much. Can you hear me okay? I just got the mute off sound, so hopefully that means that I'm good to go. So,
yes, we can hear you. Thank you.
Perfect. Okay. Yeah. So thank you very much for allowing me to talk about some of this work that I did. So I'm going back to kind of my old world when I used to work as a human factors specialist at Healthcare Human Factors at the University Health Network in Toronto. And this is some of the work that we did back when there was when Ontario was preparing for Ebola, for the potential case of a patient with Ebola. And a little bit of background to this work was there were a lot of areas also preparing for a potential case of Ebola, and there was a case out of California where nurses were preparing to go on strike over a lack of optimal personal protective equipment. So we were kind of brought in because there wasn't really an idea of what this optimal personal protective equipment should be. And a lot of procurement seemed to be driven more so by fear and what people felt was more appropriate and what people felt safer in, and not necessarily based on any kind of data. So we were brought in to really have a look at the design and use of personal protective equipment to see which was kind of safer for the users. So how we went about doing this was we went to 4 different academic hospitals in Toronto, and we recruited a number of representative users. So in this case, we had 82 participants, all different kinds of representative users, from nurses, environmental service providers, intensive care physicians. So anybody who may have had to wear the personal protective equipment and to go into the room and potentially come in contact with a patient with Ebola, they kind of formed our kind of participant pool. And we went to 4 different places. So you can see from this slide here the difference in the kind of environment in these 4 different hospitals, and where healthcare workers would have to put on and then remove their personal protective equipment. They were all kind of different shapes and sizes, and you can see that the equipment that were offered to the healthcare workers to help them to kind of say sanitize their hands and so on, and the layout of the equipment kind of varied in every hospital. So there were a number of different types of equipment that we tested, and when we called them kind of ensembles, because really we were looking at it as a complete system. So personal protective equipment also included, say, the gloves and how that connected then with the arm of the one-piece suit or the gown or the apron, and then how the headwear all connected together. So we kind of referred to it as an ensemble. And then within hospital, adult hospital 1 and 2, they had 5 different kind of variants in how PPE could be put together. So they asked if we could kind of test each of those to see which was safest. And you can see in some of the ensembles included things like powered air purifying respirators. Some included a surgical gown. Some had different types of aprons. So an apron that had kind of full sleeves versus an apron, the kind of standard apron that kind of goes around the neck. And then in 2 different hospitals, so you can see within the trauma hospital here, they also had the addition of rubber boots. And then in the pediatric hospital, we can see that these guys also had powered air purifying respirators. So just to kind of add a few pictures so that you can see some of the differences and some of the ensembles that we put together. And some of them may only seem like quite small differences, but they could often lead to different types of complexities when participants were removing the equipment. So the one on the left here, you can see they had, it's not quite clear in this image, but they had kind of some headwear that kind of came down, wrapped over in front of the neck and then was tied at the back. They also had boots, so kind of boots that weren't integrated into the one-piece suit, whereas over on the person in the middle here, this was a fully integrated one-piece suit where the shoe coverings were kind of integrated into the suit. And then you can see this person on the right, they have, these are the guys who had the boots. So they were just to kind of give you an idea of the differences in the types of equipment that we were testing. So the procedure, what did we do? So we had a number of stops throughout the procedure. So we had participants don their personal protective equipment. So we had them put it on, and this was all done within the context of where they would be doing it in a real-life session. So we actually went into, say, the emergency department or the intensive care unit, where we imagine that participants would be putting the equipment on and then use the anti-rooms available within those environments to look at where they would then be removing the equipment. So participants would put their equipment on, they would then do some tasks within the patient rooms, kind of simple tasks, kind of just bending down, reaching up, turning around, kind of look at things like the restricted field of view and so on that was kind of offered by the different types of equipment. And then after those kind of brief tasks, they would then remove the equipment. And here it says DOS primary, so the removal of the equipment was often done in pairs. And this was kind of following the protocol that had been designed by each institution. So you had your primary, who would see the person who'd gone in to see the patient. They would remove the equipment with the assistance of a secondary person who would also be wearing the equipment. So we had the primary remove their equipment, and then of course the secondary would also have to remove their equipment as well. So we included that. And within each stage of the simulation, we had a brief debrief with the participants to kind of get their feedback and their thoughts on how safe they felt and the kind of ease of kind of putting the equipment on and removing it. So as part of this then, we realized there were a number of kind of design flaws associated with the personal protective equipment. None of the ensembles that we tested were kind of designed as a complete system. So we found that shoe covers may come from one manufacturer, gloves from a different one, different headpieces and so on. They weren't necessarily designed to go together particularly well. But when we were kind of testing them, some of the things that really stood out were looking at the one-piece suits, the head coverings tended to kind of curl backwards once they'd be removed from the head. So these are the top left two images here. When participants were wearing one-piece suits, they got extremely hot. We didn't have the participants in the suits for an extended, a long period of time. That wasn't one of the things that we were measuring, but you can see in this image on the kind of bottom right here, where the participants bending over in the blue shirt, they did get quite hot in it when they were in the one-piece suits. Some issues around kind of removing aprons, particularly the aprons that went around the neck. There was a huge kind of spatter risk there. This top right image, you can see one participant attempting to remove an apron towards the secondary who's their assistants in helping them to remove. And when trying to pull around the neck there, it got quite stringy as they attempted to pull the apron away and kind of required some force. So there were a number of design flaws. I'm not going to kind of go into all of them, but 23 in total were what we kind of logged as part of the experiment. And then, of course, when we were looking at the design of the PPE, the removal of the PPE happened within an environment, and so that we realized that the environment actually kind of influenced how people were removing the PPE. So the equipment and the layout of the environment, whether or not hand sanitizer was affixed to the wall versus kind of just kind of left at the side of the sink, being able to do a visual contamination check, so a lack of mirrors and things like that, where people could kind of see if they had any contamination or where they had potentially may have some contamination on them when they were moving the equipment. We also noted in some locations there was a seat that was provided for people to kind of sit down and remove their PPE. When we actually tested the use of the seat within the actual environment, some of the spaces were just so small it wouldn't have been possible to include the seat, and they actually kind of complicated the removal of the PPE. So what we did as a next stage then was we wanted, knowing what we kind of collated all our findings around the design of PPE, and having realized the dramatic effects of the different environments, we decided that we would kind of go away, and as a next stage, we would take those findings and see if we could maybe design a kind of ultimate guide on how to kind of lay out a doffing area for safety. So we kind of attempted to redesign a doffing area with a number of different design features. So we, instead of using the chair, we attempted to include handrails. We used things like, we introduced windows, which were not always available in some of the settings where we did the testing, to see if this would improve communication. We tried to color code and position bins in very particular locations. We put a mirror, affixed it to the wall, and we used a number of different, we included a number of different design features, but then we wanted, of course, to go on and test them. So how we did this is we worked together with Sunnybrook Health Sciences Centre, and this work was also funded by the Ontario Ministry of Health and Long-Term Care. And Sunnybrook were running a number of workshops for healthcare workers across Ontario to help them to come and learn best practice in putting on and removing their personal protective equipment. And so we almost kind of piggybacked on the back of those workshops to also use that kind of doffing environment to see whether or not it improved or how it impacted participants' ability to safely remove the personal protective equipment. So for this one, we had 72 participants, and they were all, again, representative users of personal protective equipment. They worked together, so there were 36 pairs. So we had the primary, who would be the person going in to treat the patient, and then the secondary. And then for this one, we kind of applied chocolate pudding to the participants to kind of represent Ebola. So we would have this kind of visual check to see if there would have been any kind of cross-contamination, and we had each pair kind of follow their own institutional protocol. To collect the data, we had objective observational data, so we had 2 human factors specialists observe people putting on and removing the PPE, and then we also had subjective questionnaire feedback from each of the participants to get their thoughts. So some of the findings, we found that some of the features were liked and actually seemed to improve doffing safety, but then some of them did not have their intended effects, and others caused additional unforeseen safety issues. So securing hand sanitizers to the wall, including mirrors, the inclusion of the handrails, and kind of restricting the doffing area to a smaller area, we seem to all to improve doffing safety. One of the places that we tested previously had a large doffing area, and we thought that was a positive until we noticed that having that larger space meant that people were shuffling around in a larger space and potentially dragging Ebola with them as they were kind of shuffling towards the bin to throw something in the bin. So we found that restricting the space to a kind of contained movement when people are wearing the PPE, and that seemed to work well when we were testing it. But of course, some of the things that we tried to design in to overcome some of the issues that we've seen in our first stage didn't always work out the way we'd hoped. So this image I'd noticed was we tried to color code the bins. So the yellow bin would have been in the yellow zone, which is the cleaner zone, and the red bin should have been in the red zone. And at some point, the participants had swapped the bins over because one had become full and another one was quite empty. And so these kind of design features that we kind of thought, that would help people when they were kind of removing the personal protective equipment had unintended consequences. Another couple of issues that we saw was that participants were still kind of brushing up against the bins. So we can see this left image here with some kind of chocolate pudding or Ebola that's then being brushed up against the bin there. We also found that the positioning of that secondary person significantly affected doffing safety. So having that communication between the primary and the secondary, the primary always kind of turned around to talk to the secondary, which often meant that they were moving their equipment towards that person, which kind of introduced some kind of cross-contamination risks. So the overall conclusion, and it's kind of an overarching one, is really just to kind of push the importance of doing kind of evaluations with representative users, and then having them to conduct representative tasks, and really just to highlight that how important this is to kind of reveal kind of some system design issues prior to implementing any kind of procedure or complete ensemble of personal protective equipment. Because even kind of as human factors specialists, when we tried to redesign the environment, when we tested it with actual users, we realized that some of the things we had tried to implement didn't kind of make sense. So it's just the importance of kind of doing that iterative testing cycle before implementing any kind of process or PPE ensemble. And I think that is where I'm going to leave it and hand it back over to Chantal and Janet.
Thank you, Tracy. Hi, I'm Chantal Trudel, and I have Janet Britnell here with me. Hello. So we would like to thank you, Tracy, for introducing that presentation, because it has some relationships. Although we weren't looking at additional precautions in our NICU study, you do highlight some of the similar issues that we found in our study. So we're going to be talking about a study that we conducted looking at human factors and design considerations in neonatal care design. This study has just been published this month in a special issue on ergonomics, and it has also received Ottawa Health Science Network Research Ethics Board approval, as well as ethics approval from the University of Nottingham Research Ethics Board. So, of course, just some general background here. So the nature of healthcare worker tasks involve frequent contact and circulation among patients and family, healthcare workers, equipment, supplies, work accessories, furniture, and fixed objects in the environment. So the very nature of healthcare worker tasks and their activities with people and design things create a number of opportunities for transmitting pathogens and the generation of hospital-acquired infections.
So our NICU population is particularly vulnerable because of their low birth weight, underlying illnesses, immature immune systems, and very, very fragile skin. And different practices, best practices to help minimize hospital-acquired infections are put in place. We've got the 5 moments of hand hygiene, ensuring that there's adequate space between the babies, ensuring that the workflow is set up to minimize transmission risks and different breaches, as well as different cleaning and disinfecting policies and procedures. Our unit is a part of the EPIC community, which is a national network that looks at evidence-based practice and quality. And we have discovered, when comparing our practices with other centers, that there are other factors that impact this, and that could be single-use equipment, single patient rooms, dedicated hand hygiene stations, and we've discovered that through talking with our other members of EPIC. And it just really speaks to, when we compare our practices with other centers, it speaks to the variations in practice and how understandably that does happen dependent on the different center.
So it's well recognized that hand hygiene is a very important step in breaking the chain of transmission. With regards to moments of hand hygiene, this is a diagram that just illustrates the 4 moments of hand hygiene that are required in general routine care. But in neonatal practice, there's an additional step. And that additional step is very important when you look at the design of the environment. So the first moment of hand hygiene is before initial contact with patient or the environment. However, with neonates, there's an additional step where hand hygiene is required before entry into the infant's environment. And by infant environment, we mean the isolette or the CanMed bed or the infant warmer, bassinet, or cot. But this is a picture from the unit that we studied. And what it shows is the demarcation of 2 zones at the patient's bedside. This is a ward environment. It was a renovation done in 1995, so it doesn't meet the current recommendations for NICU design. But when you look at this diagram and you think about a healthcare worker having to perform hand hygiene before going into the isolette, and you think about the various best practice guidelines for IPAC, the question is, can we actually do this in reality when you look at the design of equipment and you look at the design of the environment that surrounds the infant? So the staff, for example, if they're required to perform hand hygiene before they go into the isolette designs have no provision for hand hygiene, meaning that there is no secure attachment point for hand hygiene. And then the other thing we noticed in this study is that often healthcare workers are performing tasks that could be one-handed, meaning that it's literally impossible for them to perform hand hygiene when one hand is occupied on a task while they need to perform hand hygiene in order to break the chain of transmission.
So in this picture, you see the clear demarcation and some of the challenges that Chantal spoke about not having accessible Purell right at the incubator. You can see it on the left-hand side of the picture where it's right there on the wall, but that did, because of its location, it prevented us from doing the 5 moments of hand hygiene, and we maintained a 4-moment practice. So those were some of the challenges that we encountered. We would have to ensure that hand hygiene was done. So essentially our patient environment was everything that was connected to the baby. So if you look at the picture, you see the ventilator that's attached to the baby, the monitors, the IV pumps, everything that is attached to the baby became the patient environment. So prior to the start of all of their shifts, they would wipe all of that area down to ensure that it was clean. And anytime they exited that environment, they would have to Purell using the dispenser there at the side.
And just to note, this is very common in healthcare, but the healthcare workers in the unit, in their efforts to try to achieve the 5 moments of hand hygiene, designed a number of ways to jury-rig hand hygiene onto the isolette. But the problem with that was that often the hand hygiene dispenser wasn't secure enough. It would also go missing and lost after each cleaning of the unit. So even though their efforts were unsuccessful, they're still looking at ways in which they can support this 5th moment of hand hygiene. And just to be clear, we recognize here that there are a number of factors, they're interrelated, that are involved in supporting IPAC. And we highlight at the bottom there that our main focus of this study was looking at control of the environment, specifically design of the environment and equipment around it. But what we found in our study, and this is very common in human factors, is that the factors to support IPAC, such as education and training, for example, ended up being related to design of elements within this space. So basically, our research questions recognize that, there have been great improvements in technology for neonatal care, and there's also extensive guidelines and literature specifically for NICUs in IPAC. But despite all that, studies are showing that infectious complications in neonates are still a huge challenge. So our question here was, why is this, and specifically, how might design be involved? And the purpose of this was to help the unit move forward with redesigning the unit in a more informed manner. So the first question was, well, how could we study this? We recognize that this is a complex issue. One of the frameworks we tend to use in human factors, human-centered design processes are human-centered design frameworks. And these frameworks support a number of attributes, but primarily they advocate for the strong involvement of frontline participants, and they also advocate for thorough documentation of frontline workers performing their tasks, the interactions they have with people, with things, with their environment, in order so we can understand their behaviors and the goals they're trying to achieve, and what are the barriers in achieving those goals, in this case, not breaching. These frameworks are grounded in ISO standards. So ISO started it with ISO 13407 in 1999, which was human-centered design processes for interactive systems, but it's evolved into ISO 9241, which was released in 2010, which is a whole framework of research called ergonomics of human system interaction. So the other thing that human-centered design frameworks recommend is the use of design itself as a probe to be able to investigate how we can collect more data from participants to be able to design in a more informed manner. This is just a slide showing how we planned our study. So we had a number of pre-research activities, one of which involved, just preliminary site visits to hear the concerns of staff, what they thought, what they suspected might be the issues with infection prevention control at the bedside in routine care, a thorough review of best practice IPAC literature to be able to compare with what was going on in the unit. Human factors research in IPAC and in NICUs, it's actually, there is very little information in this area. Planning the study was very important to complement the workflow of the unit. So, we recognize that nurses and healthcare workers are extremely busy. However, the context that they work in was very important to study because we knew it was going to reveal a lot of rich information about where the barriers were. So we looked at how specifically I could be on the unit with the nurses, not disturbing their work, but allowing them to participate actively in providing feedback on what issues they were facing. And one of the techniques we used for that is naturalistic observation, which requires thorough documentation of the task analysis, what is going on, as well as the physical documentation of the environment. But it also encourages participants to comment, to provide feedback, to provide clarity. So if there was something I didn't understand that was being done in a task, that I would be able to ask a participant to clarify that. If I would observe a breach, the process was that I would go up quietly afterwards and explain to the healthcare worker that I think I saw a breach, and then we would discuss it, and then I would document that conversation. So they would be able to share what their challenges were, whether they knew or thought that they had breached. And these led to more insights into their mental models about their behaviors related to infection prevention control. We also, in order to analyze this, we had a lot of data. We used thematic analysis to basically group the barriers into main themes. So in terms of the scope of the study and the stakeholders, we primarily focused on routine care at the patient bedside. We ended up studying 81 healthcare workers, predominantly nurses, but it also included studies of housekeeping, supply logistics, respiratory therapists, rounds, nurse educators were involved. We did not study family members. That was excluded from the scope of the study. And we also had the involvement of IPAC specialists from the hospital. Aside from routine care, there were specific procedures that were documented, such as blood work, TPN, tracheal intubation, lumbar puncture, and again, housekeeping, supply stocking, and rounds. 50 hours of observation were done over a complete 24-hour cycle. So we looked at, I was there on night shifts, and in order to understand if there were differences between morning, afternoon, and night shifts. And then I also received training in the NICU's hand hygiene practice, so I was very aware of what would be considered a breach and what did not constitute a breach. Several stakeholder planning and feedback meetings were conducted, and this was in order to present the findings iteratively so that we could see whether the findings were resonating with what participants felt was going on, but also whether there were aspects of the observation that needed to be clarified with subsequent observations. And from that, tracking these interactions was quite detailed. We ended up with 81 pages of data, which constitutes 497 photos, sketches of the environment with all the relevant dimensions related to best practice in IPAC. We documented supply use at the bedside for 19 individual shifts, and we ended up with essentially 46,000 words of observation documentation, 5,000 words of stakeholder meeting notes and codes, and 3,000 words of researcher memos. one of the things we did, which was quite interesting, is we studied supply use at the bedside, and I'm going to let Janet talk about this because healthcare workers suspected that supply use was responsible for some of the breaches that were occurring in the unit.
So when we spoke with the nurses, supply use has always been an issue, and the way our unit is set up, all of our supplies are kept at every bedside in drawers, as you see in the picture. And if you look back at the slide that we presented earlier about the hospital environment and the baby's environment, you can see that those drawers are right there at the bedside. And we suspected that the drawers were one of the biggest concerns for breaches, for contaminations, because of their location and the close proximity to the patient environment. So Chantal did spend a lot of time looking at this, and she created sort of a template, a tool that would allow us to track, based on the baby's acuity, the amount of supplies that we were using, because we often would run out of supplies depending on the level of acuity, and the nurse would have to, she'd go from the drawer to a supply cart in another area, which could potentially cause greater risk of transmission. So this template that she created allowed the nurses to track, and and it allowed us to track what supplies were used for what level of acuity. So the way the unit, again, is laid out is there's 3 separate rooms with the higher acuity in one room and the lesser acuity in another room, but each drawer was stocked the same way.
So I wanted to give you some of the, so again, as we said, we have 80 pages of comments and observations on related to breaches in the unit and design of the environment and equipment. But I want to give you just a sense of some of the voices of these nurses, and so here's just some excerpts of what people were saying. So I heard this a lot. Nurse E here, it would be better if the Purell was closer to the isolette since the equipment around is always ringing off. Nurse B, this is a related comment, and again, this came up quite frequently. We're constantly turning off alarms, but they're programmed to go off too often. So what this means is the physiological monitor that was located next to the isolette was perpetually ringing off. And so to silence the monitors, the nurses have to, if they're in the hospital environment, they have to hand hygiene before they do that. If they're in the reason that was one of the reasons why the equipment, one of the reasons why the equipment ended up being within the patient environment, because it was just too difficult. The nurses would be performing hand hygiene hundreds of times if they had to do that because of the number of times that they have to silence the monitors. So again, that was the rationale behind collaborating the equipment, putting together the equipment with the infant in a designated zone called the patient environment. And here's I'm speaking to one of the nurses and I asked, can you talk about your work? I tried to make this questions very general because I wanted the information to come from them. So can you talk about your work? And I just asked her about the design of the bedside and IPAC. And again, these were comments that we heard. She says, certainly the drawers, my goodness, we reach and grab, it should be readily available. And what she means by reaching and grabbing is the pressure constraints that nurses feel that they're under to perform tasks quickly at times, and also if the patient is in decline or in a serious condition that they need to have access to supplies quickly. I don't expect you to read this. It's just really to illustrate how much of the coding was helpful in identifying the issues. So all those tiny little words that you see there are all the codes that were developed to describe actions that we were seeing or comments from participants. And then the bubbled areas are the themes that start to evolve from those codes. And then what we did is we ran an instance count on words that were occurring in those codes. And what was interesting, so all on the right-hand side, there's a list of the instance count, and it's got a bunch of items in red. Well, those red items occurred over 100 times in around 100 times in the data set. And although they don't tell us why they're occurring, they basically are asking us to pay attention to why those words are occurring over and over again related to breaches. So the key words that came up, the highest instances were equipment, patient environment, supplies, bedside counter, sanitizing hands, and actually walking was another one. So walking seemed to be something that came up quite frequently in terms of observed breaches. Some of the orange codes were mentioned about 50 times, so sink, furniture, chair, drawers, waste, garbage, hospital environment, water, alarm, clean, dirty, soiled, wiping. Wiping refers to wiping with germicidal wipes, throwing out, disposing, moving, putting on, and tasks in space. So that's just to give you a sense of the things that we needed to pay attention to. These are just examples of illustrations that I used as probes, essentially, to go into the unit and also in stakeholder meetings to, I was responding to the data and drawing about, well, what if we did this? And we would draw examples of how it might be changed. And what was good about this is that nurses could look at it, or housekeepers, et cetera, and they could provide comments on, well, you know, is that going to work, or is it not going to work, and why? So it was another way to tease out some of the knowledge from frontline participants. So I'm just going to run through some of the key themes. There is so much in this study that we found that, you know, it would be impossible to share it all with you here, but we're just going to give you the broad strokes, the overall themes that we found in here, that the unit is currently, you know, in the midst of addressing some of these issues. But one of the key findings is that essentially designs lack critical features which may help break the chain of pathogen transmission. So I've shown some examples here. So the examples at the top show a healthcare worker, a nurse working at the isolette, and as you can see, there's a bunch of supplies draped on top. There's a tiny little supply tray inside the isolette, but it's nowhere near effective enough to be able to handle the actual supplies that are being used in that area. So nurses strategically try to isolate these supplies from potential soiled areas. You can see the nurse holding a little medicine cup. So she's doing workarounds to try and isolate the supplies. Down below you see on the left there's an infant warmer, and there's a small little tray, again, with sterile supplies there. So the supplies there are, they need to be stacked up because the tray actually isn't large enough for them. You see a healthcare worker in the middle. She's silencing an alarm. Again, this, you know, when Janet's done audits of this, and it's revealed that a lot of the breaches are associated with silencing the alarms. And to the right, this was probably one of the more interesting ones for me that I didn't expect. This is a ventilator at the end of the isolette, and it shows a very deep user it was revealed that there's a very deep user interface experience that the respiratory therapists must go through to be able to do their work. So essentially, it means they're tied to that piece of equipment, which is in turn tied to the child. So that's why the ventilator became part of the patient environment. And again, no provision for hand hygiene on that piece of equipment. Second theme is the designs and layouts require frequent touch and contact, and everyone is familiar with this, but there are so many areas that require frequent touch and contact within any task. That it becomes literally impossible for healthcare workers to navigate through these what are seemingly benign areas of contact. So I show handles to supply cabinets, going into a clean linen room, you have to touch the door handle, and handles on paper towel dispensers. Of course, there are some where we don't require that anymore, and all the areas, for example, on an X-ray, mobile X-ray machine that need to be wiped down. One of the third themes we found, and this was quite significant, is designs require physical and cognitive effort to navigate, use, or maintain. And what I mean by that is just the sheer amount of, workload that's imposed by having to maintain these environments. You can see at the top housekeepers who have a very difficult job. They're very limited in numbers in terms of the availability of housekeepers, and they have to clean almost every surface in awkward areas, requiring them to carry awkward postures. You can see the person on the right who's cleaning the tubing at the physiological monitor, which was quite difficult, and I observed it falling to the ground quite a few times, and she'd have to re-wipe it. You see the chair in the middle, that's the family chair, that's the patient chair, where it's very much part of the care environment because kangaroo care is performed there with mom holding the baby, or the nurse might be holding the baby. And look at all the areas that people might inadvertently touch within the environment. And again, just postural considerations. You see the nurse who's leaning over the bassinet, the cot, so there's no adjustability here, and that causes fatigue, and it causes lack of vigilance. Another theme was crowding. This is a huge one, and although the unit hasn't been renovated according to certain square footage standards, regardless, they have to navigate through this and basically come up with their own way, their own designs to be able to handle these crowding considerations. So you can see in the far corner underneath, there's rounds taking place, how many people are in rounds, and all the areas, all the equipment, furniture, and so forth that might get inadvertently touched, or soiled areas that they might touch by accident. You can see at the top the mobile X-ray machine on the left that has to come in from outside the unit and be wiped down before it comes in, and then the relatively small space that it must occupy. You see in the middle at the bottom lumbar puncture procedure and how awkward it is to navigate. And the last one is cognitive aids, and this is really important. So that's the diagram we showed you earlier, where they were trying to segment the two areas, hospital environment and patient environment, but the nurse educators don't have anywhere on the unit that's near decision-making areas, essentially at the bedside, that would help healthcare workers understand these demarcations better. So they've had to find areas wherever they're available on the walls, the fridges, and so forth to put these cognitive aids, but they're often with other documentation. So designers really need to understand that they need to design space at decision-making areas for cognitive aids. This is just showing how these are all those factors we just went through, and they are interrelated. So looking at this at a systems level is very, very important, because you might make an improvement in one area and then, but it might undermine another area. So it's very important to look at the interconnectedness of these. And our key recommendations, design cues are highly needed to be able to warn healthcare workers about what are high-risk areas, to bring attention to them. Right now, the designs are benign, as I've said. They don't have any language that indicates that. So managing and accessing and isolating supplies is a key recommendation, and then looking into touchless features. So voice activation, for example. There's tremendous advancements in technology now that could be looked at to be able to reduce touch dependency. And as I mentioned, more design that supports cognitive aids for healthcare workers. And what this resulted in, just to show you again a very short excerpt here, is a 24-page design recommendation guide, and the unit's using this currently in a number of initiatives that they have underway.
So we were very grateful for Chantal's interest and the work that she presented. And based on some of her recommendations, we felt that we had enough to support some changes in our unit. So current state, we recognize that we don't meet the standard for space between babies. and that has been a recommendation from our IPAC for a while now. But we just recently have built a 5-bed satellite nursery using existing space within the organization, and the plan is to move 5 babies from our existing numbers into that area, and keeping our 24-bed unit 24 beds, but we'll separate them a bit. So the main unit will have 18 beds, and this will allow us the required workspace between babies. We also identified that the drawers and the shelves were a big issue. And so because of that, the plan going forward is to remove those millworks and to remove the millwork and create a dedicated clean and dirty space to work. So we will keep the counter that you saw at the bedside, and that will become our dirty work surface, but we will also have a clean, portable work surface at every bedside. And having that extra space will allow us to do that. And we also recognize that the supplies were a big issue in the drawers. So we have now implemented a standardized cart system where each room has a dedicated cart based on the feedback that we had received on our supply usage. So each cart is stocked appropriately per bedside. We're in the process of securing some support from the Ministry of Health for a much larger renovation, and that has already gone into the ministry. And we also have been working with the parents to collect their feedback. You saw the chairs and the issues that we had with kangaroo care, and so we felt that it was important that their feedback be received. I guess that's about it, raising awareness through different events and working constantly with our IPAC department to ensure that we maintain our good practices. And just on a side note, based on a number of other practice changes, we have not had a central line infection since August 2016.
That's a good way to end it, Jen.
Yeah.
So thank you very much. We really appreciate your time and hearing our story, and we hope that you have successes as well in your areas that relate to IPAC.
Excellent. Thank you very much to all three of you. We do have a few questions here, which I think we should be able to get through before the top of the hour. The first one is for Chantal, and this is a question around hand sanitizer, and someone asking, is Purell the best hand sanitizer to use compared to others? They note that they're currently using Isogel. Did you have any thoughts on that, one versus the other?
Oh, I would not feel confident to comment on that, I'm afraid. Not a chemist. So I wouldn't feel comfortable commenting on that. Janet, would you?
I would divert that to our IPAC
specialist. Yeah. Do they have an IPAC specialist that could help them with that?
They may very well have an IPAC specialist who can help them with that. Thank you. Next question is for Dr. Hurley. When donning personal protective equipment, is every part of the body covered? Why or why not? Also, in regards to designing the doffing area, why not remove the bag after each personal protective equipment instead of waiting for it to overfill?
Yeah, good question. So the second part of that question about not allowing the bag to overfill, now that was something we just asked that protocol was followed. So if there was a protocol that was designed to have the bag removed and kind of taken out, then that should have been kind of followed as part of the procedure. And what we were finding is that oftentimes, even when bins got really full, they were never emptied, and people would more likely try and push stuff into the bin rather than trying to empty the bin. So one of the big learnings that I didn't really touch on was that there wasn't really a procedure for that to empty the bins. And so that was one of the kind of next phases for some of the feedback for the hospitals, was that that process of emptying the bins and stuff needed to kind of be designed in, because especially with the full one-piece suits, they were really quite large pieces of equipment, and usually after every person the bin would fill up. And I can't remember the first part of that question. If you could just remind me.
Yeah, it was in regards to why not remove the bag after each item of personal and protective equipment instead of waiting for it to overfill?
Yeah, so that was the second part. So we asked the participants to follow their protocol when removing the equipment. So if the protocol had included an option to empty the bin, then that should have been followed. What we were finding was that there was no protocol designed at that time, and so later on, having found that people prefer to kind of stuff stuff in the bin rather than empty the bin, that was kind of one of the learnings that the kind of hospital could take away. And I just noticed this question in the Q&A box. So the first part of it was looking at why it was every part of the body covered, why or why not. So it was decided, I guess, by the infection prevention and control people that it was best to have the body covered, given the kind of nature of Ebola. Now, I'm not an expert on that, but the ideal, from what I remember, was that the majority of the body needed to be covered. What we were finding as part of our evaluations is that because the PPE wasn't designed as a complete system, there were instances where there were gaps. There were gaps between, say, the gloves and the arm. There were instances where the kind of gloves had moved away from the arm, or gaps between where the headwear and the one-piece suit if the participants had moved their head, there started to be, because they weren't connected in some of the ensembles, there would become a gap around the neck. So my understanding is that the body should have been covered, but some of the instances in how the different pieces of equipment were put together, they weren't always fully covered because the equipment didn't kind of work together particularly well.
Okay, we've got two more questions, and both of these are for anyone who wants to answer. The first is, do you use a multidisciplinary team to do the diagnostic work and identify the barriers to best practice? For instance, IPAC consultants, clinical team, and leadership?
Yes, most definitely. That's from my perspective, and Janet's too, that is critical to really understanding the context of use and what the barriers are, but also the opportunities. As a designer, with experience in this, every unit's different as well. And so I rely on that multidisciplinary, interdisciplinary, essentially, collaboration to understand what issues healthcare workers are facing, but also to redesign, to come up with new designs. Otherwise, I might be at risk of imposing my preconceptions on their work.
Okay, thank you. And finally, do you need formal researchers or research support for this type of work, or can any organization use these tools to apply to issues they are encountering?
Tracy, I'll let you comment afterwards, but the human-centered design framework that I showed is actually, it's intended for industry to be able to adopt that framework, and they actually have guidelines on how much time it may take to do some of those methods. Now, the amount of time that we spent on this study is quite a lot, 50 hours of observations, and companies may not have that within their fees, for example, if you want an industry person to be looking at this. But there are ways to shorten that commitment and still gain a lot of information about the context. But you have to build it within the project and do it earlier, because especially with design, if you go ahead and you have minimal information and you go ahead and you develop a design, as Tracy pointed out with her study, is that they found by doing mock-ups that there were issues still, and that's something that in my own work we advocate strongly for. We do multiple mock-ups before we commit to a design.
Yeah, and I guess just to add is when kind of evaluating the design of something called kind of a potential mitigation strategy, it was always best to kind of have a professional kind of, like a human factors professional to do those observations, but it doesn't necessarily always have to be that. The main thing is really just to kind of do those kind of simulations and do those observations independently to really get a good idea of kind of what actually happens, especially within the context within which that those kind of actions will be performed. So whether it's removing the personal protective equipment, like we know there's tons of issues around kind of the kind of size of the ante-rooms, where information should be placed on the wall, and just kind of doing those observations, whether or not it was by us or kind of another member of staff, was really, really insightful, so that when a patient, if there was a patient that had arrived and they had to kind of follow the protocol, then everything was kind of designed to make it easier for people to do the kind of right thing at the right time.
Perfect. Thank you very much. Thanks to our speakers and to everyone who participated today. I hope the call was valuable in your work. Once you exit the call, you'll be prompted to take a very brief survey. Your feedback is instrumental, as we're always looking to improve on the webinars that we do offer. With that, we'll close the call. So thank you very much, and have a great day, everyone.